Good morning, everybody. We're going to give it just a few minutes to allow people to drop into the meeting, and we'll get started shortly.
Welcome. Thank you for joining us today as we bring you another educational session. This one is on DirectARC, Proton arc at full speed. This is presented by Mevion Medical Systems. My name is Jennifer Majori. I'm the Executive Director for the National Association for Proton Therapy. And just a reminder that this is an educational program for sharing knowledge and resources, not an endorsement of products or services. Before we begin, I do want to take a moment to acknowledge that today is Juneteenth, and we have a lot of an international audience as well. So I just want to let you know that this is a day that we commemorate the end of slavery in the United States and reminds us of our ongoing work that we all work hard to advance equity in healthcare and ensure that we close disparity gaps through policy and geographic availability of proton therapy. For those of you who don't know who NAPT is, we are a trade association. We're a non-for-profit mission-driven organization, and we represent 50 health systems. These are providers of proton therapy or those that are developing and under construction as well. We are dedicated to increasing patient access to proton therapy, and we work very hard with collaboration of education, research, in moving the industry forward with policy advancements as well. Just a few announcements to share with the group, just so you know, many of our members are on Connected Community. That is our member resource page. I just want to remind you that we have a few webinars that are coming up. Some of these are member only and some are open to the public as well. So if you check our event site, you'll be able to see which ones are coming up. We have one coming up in July regarding the role of nurse practitioners in the clinical setting as well. I also want to let you know that our conference in 2026 is a very fun location. We'll be in Nashville, Tennessee, home of boots and country music. And so we're excited to be able to offer that education with Tennessee Oncology. Look for a call for abstracts a little bit later in the year as well. And I also want to let you know that we'll be at Astro along with many of our members and along with our corporate partners as well. And so we have some activities there. So look for NAPT at Astro then. I do want to let you know that this is going to be recorded. So if you have others in your organization that would like to join or listen to this at a later date, we will be sharing that with our corporate partner Mevion and our members as well. So I want to thank Mevion Medical Systems, especially Lionel and Tina Yu, for their support of NAPT and really the industry as a whole. They've been a great partner with us for many, many years, and we appreciate this collaboration throughout the year. And this is one opportunity we have to join and collaborate on educational offerings. So Lionel, you have a great panel. A lot of interest in this topic, so we're very excited. I'm going to turn it over to you to start the session.
Thank you, Jennifer, and good morning, good afternoon, good evening, wherever you're from. So thank you for joining us for an exciting topic. Today we have 4 speakers, including myself. I'm the SVP of Commercial Development. 3 of the speakers you can see are Mevion speakers, Dr. Skip Rosenfeld, Mark John, and myself. The 3 of us have been so it's the company for each of us about 20 years. I believe the oldest in the company since 2005 is Skip and Mark Jones as well, and myself 2007. So you have a tremendous amount of expertise of history here in proton therapy from a technical and a clinical standpoint. And then we are very fortunate to have Dr. Mark Newpower from Oklahoma University, who has been one of a clinical partner for many years, doing outstanding work with the proton therapy system, and that would be talking about his experience with the DirectARC from Mevion. So Mevion today, we are 21 years old. And we are today a proven US leaders in proton therapy, and we are very proud of that. We were established in 2004 in Massachusetts. We delivered the first compact proton centers worldwide with our partner, Washington University, the first clinical HYPERSCAN system with a proton MLC in 2018. 2024 has been very exciting to us. We were recognized by the Commonwealth of Massachusetts as a very strong US manufacturer, job creator in our state. And that has been a very, very proud moment. And 2025 is starting also very well, where we are launching the DirectARC technology as well as the FIT system, the first Proton system that fits into a LINAC vault. So after 21 years today, we have clinically proven with as long as 12 years track record of clinical use, our technology from an uptime, workflow integration, and adaptability. Most exciting is when our customers are treating patients with a high precision. And one of the customers just reached a 10 years milestone, treating 3,000 patients over these 10 years. And this is 3,000 patients that we are very excited that we're able to receive proton therapy. The customer impact and the clinical impact is also all through the pediatric community. Washington University, Huntsman Cancer Institute, Oklahoma University, Rutgers Cancer Institute, and many other NCI designated cancer centers are heavily treated pediatric patients. And this is why we are in proton therapy is ready to make a big change. And the pride that we have today of being built in the US, designed, built, and supported in Massachusetts. So it's been an interesting recent year with the ISTRO and Pedagogue doing innovation survey about proton therapy and ask the questions on what do you see will make the biggest impact in proton therapy. And what's very exciting is on top of this survey during these two conferences, ARC and Upright are ranked at the top. And this is what Mevion today deliver with the DirectARC and the Mevion S250 FIT. So very exciting to see that the technology that we are developing is being supported by the direction that the industry and the clinical part, the clinicians are also looking at. Our goal is always to be clinically focused and technically ready and fully supported by research. Research has been an incredible partner, and we'll discuss it a little more in a few moments. So today we have one platform, the S250, but two technology, the gantry system, the Mevion S250i that has been in use for the past 12 years. It's compact, it supports HYPERSCAN, has a DirectARC and onboard diagnostic CT imaging, the fastest installation, 6 months accelerated installation. And then we are launching the Mevion S250 FIT, which is an upright treatment that do fit into a LINAC size room. Also HYPERSCAN, DirectARC, diagnostic CT, a faster deployment because you have a simpler installation but a simpler room readiness. And here's an example of two of our partners. Today, we are delivering the technology. We are, we are constructing and we are modifying vaults. So on the left is our partner, Stanford Cancer Institute, which has modified one of their vaults to bring the FIT system. You can see the cyclotron that was just delivered in January. And on the right is Atlantic Health System that modify their X-ray LINAC to be able to bring the FIT proton therapy system. So very exciting, the room requirements such that institutions like Stanford and Atlantic Health are bringing the proton therapy within the existing department, within the existing LINAC vault. So in the next 45 minutes, you will hear how DirectARC is reshaping what's possible with proton arc therapy, both for the FIT system and also the S250i. So with that, I'm going to introduce Dr. Skip Rosenthal, Senior Vice President of Clinical Affairs, that has been in proton therapy for, I always joke around, for a very long time, for 35 years, but a tremendous amount of expertise. Skip has trained many of us as physicists in proton therapy, and it's great to have him today, continuing to talk and see about what's the impact of DirectARC has on proton therapy. Skip.
Thank you. Thank you, Lionel. I'm really pleased to join you and describe this next step in the journey of making proton therapy an even more powerful tool for clinicians in their battle against cancer. This field just continues to evolve, and I'm really excited to describe some of the stuff I've seen over the last few years. But I want to go back first to something you're all quite familiar with, which is the advances in conventional photon external beam therapy over the last 40 years, as an introduction to where the whole ARC concept comes from. It's worth reviewing how the physicists and the physicians all through the years have imagined better ways to improve the therapeutic ratio using, at the time, widely available linacs. In the 1980s, the advent of CT imaging, which, by the way, was first developed for proton therapy as a planning tool, but was adopted for conventional photons, allowed the visualization of tumors from the beam's eye view. And from that view, you could conceive and fabricate collimating blocks that were conformal to the targets that you were aiming at. You could add wedges, as you had before, and importantly, you could predict the dose in 3 dimensions on the planning systems that were available at the time. And this was the generation of what was called 3D conformal radiation therapy. It used the collimating blocks to fully cover the target from several standard directions. But then some clever people imagined that if you had an active multi-leaf collimator, you could use that to contour the beam from many, many directions. And you could even vary the intensity of the beam from each direction across the field. And by doing so, you could make the dose even more conformal, with less treatment overhead. But this required a mathematical leap, which was known as inverse planning, in order to take advantage of these new tools that were imagined. As the computational power increased, it was seen that continuously moving the gantry while varying the beam intensity could be both fast and a more effective treatment. Fully developing what eventually came to be marketed, we see here as VMAT or RapidARC from Varian, pushed inverse planning and dose optimization to include the gantry angle speed, and not giving up on the intensity variation which the multi-leaf provided, or the dose rate mapping. So this is now standard for advanced photon therapy. And arc radiotherapy everywhere improves conformality, reduces unwarranted dose to normal structures, and in many cases speeds up treatment. So we don't throw away the advances in technology as we developed more computation and more capabilities to use these tools. That brings me to proton therapy, which I've been witnessing for over 35 years now, and it seems to follow a similar path, but with the extra dimension that the beams in proton therapy stop at planned depths in the patient. So if we travel through the years with protons from the early 80s through about 2010, proton therapy was practiced at first by a few laboratories and then a number of hospitals, and they relied on what was known as passively scattered proton beams. The use of the CT scanning planning tools was essential so that we could design where the Bragg peak, which is where the proton dose distribution shape comes from. We could design where it would stop, but we could also spread it out using modulator wheels to cover a target and apply this from multiple directions. Here's shown for simplicity, a prostate case using 2 directions where we completely cover the target with a uniform spread out Bragg peak. Computer designed collimating blocks and range compensators were important tools also generated by the treatment planning system to improve the conformality and the penumbra in both the lateral and the distal directions using what was called a range compensator at the time. It didn't take long to imagine that scanned pencil beams could be used to modulate the beam intensity spot by spot. In the 1990s, PSI conceived of and developed an early version of spot scanning. And with spot scanning, you can put intensity where you want it. You could emulate the spread out Bragg peak that you had without using modulator wheels. And initially, that's how plans were developed with something called single field uniform dose. But you could also vary the intensity from every direction with non-uniform dose, such that the target dose is now uniform and at the prescription. But every beam is got variations along at each spot. And this became known as IMPT, intensity modulated proton therapy, modeling what had been done with IMRT for photons, while preserving the benefits of conformality and depth from each direction. Optimized planning algorithms and computational power needed to catch up, as did vendors, so that they could safely deliver scanned proton beamlets magnetically scanned at all clinical energies. And the vendors caught up, and it took a while. It wasn't until around 2010 that the computational skills for good IMPT arrived. And Mevion in 2017 added the concept of a practical MLC, as we had on photons, to their machines. And this further improved the lateral gradients. But by that time, RayStation, which is our partner for treatment planning, was able to model MLCs from every direction and at every energy layer. And this was a major step forward for conformality and sparing adjacent structures at all depths in the target and in the tissue. This is called IMPT, with intensity varying across the field. The sum of all beams, again, deliver uniform dose to the target, and we more conformally spare the adjacent tissue through this optimized plan. Well, let's bring it up to a few years ago, where the idea of seeing if ARC plans could do for protons what they had for photons. The attraction of VMAT, which had progressed to really improve the quality of photon plans, was very dramatic, and a lot of people were looking at doing the same for protons. First, by simply creating many beams at multiple angles and optimizing each of them with the existing optimizer, we can simulate proton arc therapy. So this was sort of a manual proton arc therapy, which was born a few years ago. And we've practiced that for a while in our models, and some sites have actually done that as well. In 2023, RayStation released a version which facilitated proton arc planning. And we see in this simple case, again, for simplicity, I'm picking a prostate, by merely spreading out two parallel opposed fields into 6 quasilateral fields, we improve the dose to critical structures. Importantly, this early ARC design retained all the degrees of freedom of the IMPT plan, that being multi-energy spots, aperture collimation from all portals. The optimizer does the work of using these parameters to meet even more stringent goals that we hope to use to get to with proton arc therapy. You see in this, again, prostate case, the spread out, on the next slide here, the spread out fields and the dose distribution of sparing the femoral heads and the rectum, while reducing the entrance dose from the lateral sides by spreading it out over a larger area. The next slide shows what we call DirectARC, which again starts out as a manually adding up fields, but we looked at all of the cases that we typically see treated with our Mevion S250 machine. And in all cases, the ARC plans improved or at least met the IMPT quality. And I'll talk in a minute about how it doesn't actually increase delivery time, even though we get the complexity of a much larger number of beams. These fields here all were increased to about between 6 and 22 fields delivered in an ARC pattern. But the optimal number of beams took another step forward in treatment planning, which is now available in 2024. And Dr. Newpower will address his experience using this even more advanced ARC planning tool to create direct ARC plans. On this slide, I take one of our fields, which was a 9-field ARC for a basic skull treatment, a head and neck treatment, actually. And we look at what limits or facilitates the timing of this ARC. So one thing we see here is the patient has to rotate, or the gantry has to rotate. And in both our gantry and our upright chair system, the rate of rotation is 1 RPM. So that's a piece of the delivery, but it is semi-continuous and adds about 60 seconds for full rotation. Then we said we want to change the energy at every arc, if at every portal, if needed. But with our fast energy modulating system, changing the energy doesn't add a lot of time. In this model, it was about 3 seconds per field to change all the energies. The spot delivery requires scanning, magnetically scanning across the field, and that adds about 9 seconds per field. And finally, with the Mevion S250 HYPERSCAN, we have the adaptive aperture, which moves and adds additional collimation where needed, and that added about 22 seconds per field. So in this little example, we come up with a total treatment time of 5.5 minutes. Now, you noticed I didn't mention going in and out of the room between fields because we don't want to do that anymore. The whole point of ARC is you take all of these individual fields and concatenate them into a single field, either initially manually or now with the modern tools in RayStation, it's done automatically so that a single button push provides delivery of all of the fields. Along with that comes the responsibility of monitoring the motion remotely. So all ARC systems from all vendors need to carefully monitor what's going on in the room with remote tools, which we have on both the gantry system and the fixed beam upright system, which makes the ARC deliveries limited only by the times you see on this slide. While we were doing that, other folks were modeling ARC systems independently, extracted from a paper from the Miro lab in Belgium, where they used the modern RayStation tools. They modeled what the delivery time would be for conventional IMPT and their ARC systems. We've extrapolated that to what it would be with a Mevion ARC, again, folding in the energy layer switching time, the proton multi-leaf motion time, the spot switching, the pulse charge, and the gantry motion. And this is 10 lung cases that were extracted from that independent study. And in all cases, I think except one, the ARC system was faster than the previous IMPT system without compromising quality. That brings us to the tools available today. The RayStation 2024A is in release, and it contains DirectARC optimization. And as opposed to manually putting fields together, it allows the planner to start with full 360-degree beam availability. And at each angle, it retains the degree of freedom of full energy selection. And this, by the way, enables robust optimization because we don't limit the energy at every angle, and we can use the robust optimizer to select the best, most robust energies. The MLC is active at every energy layer in our optimization model. And then when it's done with optimizing all of these 360 degrees, it can winnow it down to the essential angles, as Dr. Neupau will describe in his talk, to perhaps the 20 or 30 most useful angles and pull them together as a single ARC delivery field. And then I said this is fully supported today in RayStation 2024 for the gantry system, and next year it will be released for the FIT system. And Dr. Neupau will show how the structures are spared very nicely with this capability. I had one more point that I wanted to make that's very exciting. I find exciting about the next generation of proton machines. For many years now, we've seen researchers modeling what's called LET, which affects the RBE, the biological effect of protons. And they noticed there's an advantage of placing Bragg peaks inside the tumor to avoid the uncertainty of the RBE effect at the end of range near critical structures. Well, with ARC plans, there's a lot of possibility for putting more of these Bragg peaks inside the structure. And RayStation now, for a number of years, has allowed LET planning and LET optimization. And you can begin to add that to your ARC plan as well. This on the right here, this article from the Green Journal in 2024 shows LET optimization, putting the higher dose spots well inside the target as opposed to the edges of the target in this ARC plan. In addition, very exciting last year and recently, publications at Astro and from research themselves describe what's come to be known as shoot-through beams. Shoot-through beams are beams that pass through the patient, and the dose delivered to the patient is done by the more proximal part of the Bragg peak. The proximal part of the Bragg peak has improved sharpness. The penumbra of these shoot-through beams is much greater, and you can use it selectively to put a much sharper penumbra where there's a critical structure abutting the target in any particular direction. But once you add the shoot-through beams, we have to make certain modifications of the room. In the next slide, we see that in our direct beam room, we have a beam stop, which has to intercept the beam after it passes through the patient. Well, that allows shoot-through plans to be delivered, but it also gives us the opportunity to put an imaging panel there. And an imaging panel there can create the tool that's known as proton radiography. So if we have an imaging panel, we have beams passing all the way through the patient. We can analyze a pattern of beams which scan across the interesting structures in the patient and create what's called a proton radiograph. And in this radiograph, you can see the variation effects of range that might change day to day, or patient motion even during the treatment. These radiographs can be taken in real time while the treatment is going on. Between treatment beams or even interleaved with a single treatment beam, you can deliver a low dose of shoot-through protons and capture a radiograph such as this. And it's fully interleaved with the treatment layers. This is all stuff that's got me very interested, preventing me from retiring just to see where this whole field is going. I'm very excited that we have improved plan qualities by adding these modalities and not sacrificing any of the degrees of freedom that we've developed over the years, starting with compact systems, gantry systems, and now multi-leaf collimators and ARC systems. There's no overhead on the QA, and the hardware is being fully developed and supported by RayStation. With that, I'd like to introduce Mark Jones, who's going to talk about his work and how the innards of this delivery takes place. Mark?
Thanks, Skip. Thanks for that introduction. As you said, my name is Mark Jones. I'm the Chief Technology Officer here at Mevion. And my objective here is to try to explain some of the technical advantages of DirectARC and a little bit more about how we achieve those. First off, the DirectARC is significantly enabled by our HYPERSCAN direct beam system architecture, and I'll explain a little bit more detail why that is important and how direct beam accomplishes that. As Skip demonstrated, treatment plans benefit significantly from the increase in angular degrees of freedom. DirectARC provides this benefit as well. DirectARC adds the angular degrees of freedom without sacrificing or over-constraining the energies delivered at each angle. For protons, a significant difference from VMAT with photons is the need to vary the beam energy. This need creates a new challenge for deliverable proton arc therapy. Direct beam addresses this challenge by providing very fast energy layer switching. That is as fast as 50 milliseconds per layer. Next slide. DirectARC with direct beam provides significant treatment planning benefits as well. With fast up or down energy layer switching, there is reduced impact on arc delivery times, and the times are independent of energy order or direction. Because of this, There is no need for constraining the energy layers or order in the treatment plan optimization. The elimination of this constraint significantly reduces the plan optimization times from perhaps hours down to just minutes. You can go to the next slide. Yep. So let's dive a little bit into the details of how direct beam works. Presented here is the Mevion S250 FIT system with the superconducting synchrocyclotron on the left. To the right of that is a cross-section through the nozzle in the center of this image. And to the right is a cross-section through the Leo Cancer Care chair and CT system. The accelerator and the nozzle presented here are essentially identical to that's in the Mevion S250i gantry system that has treated more than 12,000 patients. Next slide, please. So at the heart of the direct beam is the nozzle. So let's zoom in a little bit into what's included in that. Located at the accelerator beam exit is our high-speed two-axis air core scanning magnet. Downstream of that is our dosimetry system, which accurately measures every beam pulse from the accelerator. Downstream of that is the fast energy modulation system. And finally, the dynamic proton MLC that can collimate the beam at any energy. You can go to the next slide. At the heart of the direct beam is the nozzle. Excuse me. So why does the energy switching time matter? When the switching times are slow, it can significantly affect the delivery time of an ARC, which typically has more energies than in an IMPT plan. To mitigate the slow delivery times, the number and the order of the energy layers must be constrained in the optimization. This constraint limits the treatment plan optimization capability, robustness, and increases the optimization duration. You can advance slide. So in comparison, fast energy layer switching, these drawbacks are eliminated or significantly reduced. Delivery times are fast, treatment plans are more optimal, and the optimizations are fast as well. Next slide, please. So how does the direct beam achieve this fast energy layer switching? The animation on the left illustrates the motion of the range shifter plates that are in white here, and the blue lines illustrate the beam being modulated by those plates. The video on the right is a 1 liter spherical field being delivered into a scintillator. The speed of layer switching is quite evident here. The energy modulation system in the nozzle uses a method that we call scan synchronous energy switching. In other words, the beam is being delivered while the plates are moving. You can advance to the next slide. So DirectARC is available in both our upright and gantry systems, but there are some differences in capability and availability in timing. The FIT system has the capability to deliver a 360-degree continuous arc. It will be available with the release of RayStation 2026 and FDA approval of the FIT system. And it will enable shoot-through arc delivery as well. DirectARC is available with the S250 gantry system today, with a RayStation already FDA approved. The gantry system is limited to a continuous arc of only 190 degrees. Of course, you can do a 360-degree arc in 2 sequential arcs. And there are additional delivery time optimizations efforts in progress now. And with that, I'll conclude my portion of the presentation, hand it off to Dr. Mark Neupauer, and he will present his experience with planning DirectARC treatments at Oklahoma University Health. Mark.
All right, thanks, Mark. I'm Mark Neupauer. I'm a medical physicist at the University of Oklahoma Health Sciences Center. And I'm going to talk a little bit about some of my experience doing bilateral head and neck treatments with the HYPERSCAN system. So yeah, next slide. So recently there's been a ton of interest, obviously, as we've already covered, in proton arc therapy. I mean, a couple of us were just at PT-COG in Buenos Aires, and lots of good abstracts and talks about arc therapy. Clinically, when we talk about IMPT plans for head and neck cancer, we're talking about 4 to 6 beams. But when we talk about going to arcs, we are going to talk about using 15 to 30 beams in that range. So that increase in beams gives us more sparing, better target conformality. And so really what I want to share today is, my experience looking at what this arc therapy would look like on our Mevion HYPERSCAN system that we've been treating at OU since 2019. Next slide. Yeah, and these are all the, you can click through a couple of times, Lionel. These are, all these different abstracts just recently at PT-COG. So lots of interest in arc therapy. So what I'm going to show today is I grabbed 2 head and neck cancer patients from our patient database. And what I did was to create DirectARC plans and compared those to the IMPT plans. In general, we were looking to meet the Timmerman constraints for conventional fractionation. And then I use the same clinical settings as our regular IMPT plans. The goal for me for this work is let's create something that's actually deliverable on our machine, something that we can actually do. And so I designed this using RayStation 2024A. They have a module that you can convert an ARC plan to a PBS. It's just with a single click. And so that's what I did. And on these patients, I put a particular emphasis on sparing the carotids because my physician colleague, that's one of her big concerns. So the 2 patients I'm going to present, I'll go in more detail in a few slides, but we have a single ISO plan that's spread across 360 degrees using 16 total beams. And then the second patient required a double isocenter because of the field size. And so the angle that I chose to optimize through is a little less than 360 degrees, but uses 24 beams. So the first patient is a bilateral head and neck cancer patient, 35 fractions, CTVs going to 5940 and 7000 centigrade. And particularly, we want to pay attention to the carotids, brainstem, spinal cord, larynx, and tongue. The IMPT plan that we developed and we actually treated this patient with was with 5 beams. And then the DirectARC plan that I created was with 16 beams. And so here's just a kind of a quick cutaway to help you sort of visualize what these patients look like. On the left side, you can see that we've got the 2 CTVs, rather large CTVs, and then you can see on the other 2 views, the coronal and the sagittal. You can see, these are pretty big fields. They're right next to the carotids, even close to the brainstem. And these are very, very challenging cases to plan. And so next slide. And so what we do in RayStation is with this 360 degree coverage we're able to get with just a single couch kick. And this is what the arc angles look like. You can see these are 8 of the angles. And then we would kick the couch and do the other 8 for the other side to get that full 360 degrees. And then so here's the DBH for these patients. You can see starting on the far right, the CTV coverage for the CTV 7000 and the CTV 5940 is pretty close. There's a little bit cooler on the CTV 7000, but more or less, these are the same. But then we start looking at some of the dosimetric benefits, better sparing of the tongue. The larynx was better, and we got some pretty good sparing on the carotids. And then, of course, also the brainstem and the spinal cord got better. And so if you go to the next slide, again, I wanted to focus on the carotids. So if you look at the DirectARC versus the IMPT, we're able to drop that the mean dose on the carotids down 500 centigrade, which translates to a normal tissue complication probability decrease, maybe almost half, depending upon it is. So these are big clinical gains for 700 centigrade that the physicians would love to see. Next slide. Yeah, and so patient 2, similar patient, had bilateral head and neck cancer, 30 fractions, CTVs going to 6,000 and 5,600. Carotids, brainstem, the eyes in particular for this one, I want to pay attention to, and the mandible. This was a very challenging plan that we developed. We had to do a 9-beam double isocenter plan that takes a lot of time to deliver. And this patient's on the table for a while just because of those 9 angles. But with the DirectARC plan, we were able to come up with a 24 beam plan, also double ISO, and then we'll see the dosimetric sparing here on the next slide, or sorry, in a few slides. But you can see here the CTV is right in between the eyes. That's a very, very tough place to have to treat, to worry about sparing the eyes. And then you can also see there's nodal chains bilaterally running down the neck. And so these are this is about as tough as it gets for a clinical physicist and our dosimetry team. When these come through our shop, these are about the toughest cases that we can get. So with the next slide, you can see this is the breakdown of the isocenter and the angles that I used for the upper isocenter, where the target was right between the eyes. We needed to get some beams, directly on anteriorly, but you can see as we go lower that we're more looking at, in the lower isocenter, we're more focused on the chains on either side of the neck, so we could give up that anterior direct beam and focus more on the lateral beams. Next slide. And so here are some of the dramatic differences in our DVH here. So you can see right away that even for the same coverage level, the DirectARC plans tend to fall off very, very rapidly. The dose falls off much more rapidly. And then as you start at the right side of the DVH and then move left, you can see that the eye sparing between the IMPT and the DirectARC plans was significant. You can see those huge differences in that DVH. The mandible was spared a little bit better, some volume sparing. And then the parotids were spared significantly better. You can see those differences between the dash lines and the solid lines. When I showed that to our physician, she was ecstatic. She said, "Let's do this tomorrow. Let's put this in." And then of course we also got better sparing on the brainstem. And so when you look at the doses to the parotids, you can see that. Oh, go back one there. You can see that we were able to basically cut the dose of the parotids in half, and that leads to between maybe 3 and 4 times of a NTCP decrease. So these are when you show this to a physician, they're excited. They love seeing stuff like this. And so with all those beam angles, we can really sculpt the dose around those parotids and really able to spare them really well. Next slide. And so overall, these DirectARC plans, when we compare them to our clinical IMPT plans, we're better able to spare the OARs, particularly the parotids. We get a more uniform dose to the CTV, which I've kind of illustrated here on the graphic here. On the left side, this is the DirectARC plan. The red in this color wash here is 7,000 centigrade. So you can see it's pretty uniform. There's some hot spots, but overall, that's a pretty flat, uniform dose, and that's why you see that very vertical lines on those DVHs. But then on the right side, on the IMPT plans, because of those limited beam angles, we end up having a lot more heterogeneous dose in the target. So you can see at that same 7,000, that same color scale here, we've got more hotspots in the CTV, and with DirectARC, we're able to keep those CTV hotspots lower. And kind of looking at more of the clinical technical stuff, me as a medical physicist, one of the questions is, well, are these plans robust? So the 16 plan, that patient 1, we did the robustness analysis in RayStation, and it passed our clinical robustness standards after we've converted the beam to PBS. So as far as a robustness standard goes, like, we're happy with this plan. We're good to treat with these. So these are edging closer to something that we would be comfortable treating on a real patient, as soon as we could. And then Skip was talking a little bit about the difference between what's like a 20 beam plan versus a 30 beam plan. So I did a simple exercise looking at 20 beams versus 16 beams for that first patient. The solid line is the 16 beam plan, and the dash line is the 20 beam. You can see they're pretty close. The CTVs, which are the blue and the pink on the right, those are pretty much the same. And you can see the other structures. There's some small differences. The dash line with that 20 beam, you can see a little bit better sparing, but I don't think this, in light of what the delivery time maybe would be between 16 and 20, I don't think that really moves the needle. But it basically goes to show you that we can drop the number of beams down even with this ARC planning, and we can get dosimetrically still very almost equivalent plans. And then I went and recently we actually QA'd that first patient, and I know there's a question in the chat, but we went ahead and we QA'd the patient in the same way that we would QA our normal plans, and by and we were able to get a QA that passed actually very, very well. These are the same tolerances we use on a clinical plan, that I would review. And so these plans were deliverable on our machine with these 16 beams, and that we were able to pass the QA as well. So we feel really good that these are something that we can actually do on our HYPERSCAN system today. And so to kind of wrap this up, we're starting to see in the literature that IMPT is starting to demonstrate superior outcomes compared to IMRT. We're starting to see a decrease in toxicities with IMPT. And in this study, DirectARC offers even better dose distributions than IMPT. So naturally, I think that leads the question is, could these DirectARC plans lead to better outcomes even compared to IMPT? And then there's other interesting technical things. Could we use proton shoot through to improve conformality, to really take advantage of those sharp penumbras for those higher energies? There's a good question of how many beams is enough. Is 30 beams enough? 20, 15? There's a lot of work that we can do to figure out what that ultimate trade-off between minimizing the beams and maximizing our deliverability versus what's a great plan dosimetrically. And then something that's interesting to me that Skip kind of touched on is LET optimization. I think it's important to remember the high LET has to go somewhere. We do have to dump the high LET somewhere, but when we can increase the number of angles, the number of beams, we can really sculpt where that LET goes. And so I think we can really unlock sort of the potential of what we can do with LET optimization by using ARCs. And then these are slides from my physician colleague, Christina Henson. She's on several national level trials and is really kind of a leader in the head and neck cancer space. And so I asked her to share some of her thoughts. And actually Skip even had a great introduction when we talk about going from 3D conformal to IMRT to VMAT. We're seeing kind of the same thing with protons. When we went from step and shoot IMRT to VMAT, we significantly improved conformality. The doses, the parotids, and the oral cavities got a lot better with that VMAT. And right now, we're kind of at that transition phase with proton therapy. With IMPT, we're kind of limited by the number of feasible beam angles in terms of delivery time. We would never deliver a 20 beam plan clinically just because the patient's on the table for too long. But with the advancements with DirectARC, we can combine the benefits of proton therapy, that brag peak with the conformality of ARC therapy. So when she, as a physician, is looking at that, she's anticipating, these huge benefits of plan quality, which we've kind of already seen through our treatment planning studies, reduced doses to the OARs, like I showed, especially with those parotids. She even said, perhaps this could become a new standard of care. You can see also that it's not just limited to head and neck cancer. We could apply this to other disease sites, and then we could even have higher patient throughput, like we have nowadays with I know some places VMAT time slots might be as short as 10 minutes on their Linacs. So maybe we can be edging that way as far as what we can be able to do with our proton practice. Next slide. And then, so that's what I have. I just want to acknowledge my grad student and my colleagues, my physician physics colleagues, and Mo Siddiqui from Ray Station, who has been instrumental in helping with this work. Thank you.
Thank you, Dr. Newpower. The next speakers, or the next presentation is going to be discussing the DirectARC investigation and how they are enabling this ARC optimization. So unfortunately, the research speaker had an emergency and was not able to present today. So Skip and myself will be discussing the slide that we have received from research, and I mean, a great partnership overall between Mevion and research. So the first thing is really looking at race stations around the globe. Race stations has 129 particle and BMCT centers in 21 countries. They are the clear leader in particle therapy and in particle therapy. So they have been an incredible partner to a lot of us in the industry, and for Mevion, this is a 10+ year journey of a very successful collaboration starting in 2014, where we announced a strategic partnership that led to the use of the REST station system at one of our customers for the double scattering in 2019. We expanded that partnership with the HYPERSCAN and continued in 2021 and today looking into flash treatment as well as you saw here with the arc therapy. And these are two very nice video showing the horizontal versus the vertical axis of rotations, right? And both of these are supported by research, by REST stations. So the one on the left is supported today, the one on the right for the upright and the fit system will be supported next year in the 2026 REST station release. So why Proton arc, and that's what we've been discussing all along, is really adding one more degree of freedom, right? It's as we see from the use for evolution of X-ray and now the evolution of Proton is the ability to add more degrees of freedom. And here we add one more degree of freedom, which is the rotation around the patient. So we see this great improvement, this significant improvement that may have some clinical significance, some important clinical significance as we move to ARC. It's an improvement of dose as well as ADT. It's a faster delivery. It's simpler. There's no field adjustment. You just, as Skip was mentioning, is a single button push. Now, as you add more of this beam, there is an increased robustness that needs to be considered. It is more a challenge, and Dr. Newpower was showing some of the robustness of the ARC plan that he developed.
Yeah, Lionel, I would
Yeah.
just say the robustness question is aggravated by any concepts where you have many beam, many angles, and at every angle you have perhaps a single energy. Now you get this interplay. Is the target moving while the gantry is moving? So it's this interplay between motion that's hard to model, but a real effect. So, but when you go to the gantry, if you include many angles with multiple energy layers, the robustness is improved just by that alone. So it's delivering more of the target coverage from a single place in a short amount of time that eliminates the very important deficiency of interplay when you deliver just a part of the target and then move the gantry. So that's one of the concerns that we've addressed by allowing to selection of fewer angles where each angle contains more or less complete coverage of most of the target.
Thank you, Skip. So the Proton arc investigations, as discussed, has been available in 2023B, and it's an option that can be selected, and then once it's connected, it's actually quite interesting from an optimization standpoint. And as Skip mentioned, and it's especially true for the DirectARC, is this ability to optimize on energies and therefore on depth of coverage for each of these arc angles that are selected. So that is a significant improvement over the dynamic or IMPT treatments. So this is an interesting slide that research has been presenting, looking at different techniques: the optimization time, the delivery time, the plan qualities, the dosimetric uncertainty, and the hardware upgrade. And they're looking at four techniques: the dynamic arc, the static arc, converted static arc, and IMPT, and we'll talk right after about how the DirectARC is fitting. But we see that optimization's time it takes longer as you have more complex technology compared to the MPT. The delivery time gets faster as with the ARC technique. The plan quality gets also better as we demonstrated. The problems as discussed here specifically for the dynamic ARC, where you have you don't have this ability to optimize energies very simply because of the slow, or at least for the slow energy switching, the dosimetric uncertainty is higher. And then for hardware upgrade, well, the typical dynamic arc and static arc do require upgrade. But when we look and we bring, actually, we'll bring that in the next slide, because this is another interesting one. And maybe Skip, you can talk about this hybrid arc example, which is quite exciting.
Well, it's interesting because it demonstrates both what happens when you have a single energy delivery. Yeah, the gantry is moving through many angles, but at every angle, it's just delivering a single energy. And then when you see it stop for a moment, it's actually delivering all of the angles, all of the energies that are needed at that angle, as well as the collimation. So it's a very interesting graphic that that shows that. And the overhead of stopping at some of these angles is more than compensated for by the robustness and the quality of the plan, which is deficient when you only deliver a single energy at one angle, as Mark was showing us earlier. So yeah, I think it's a nice graphic. I don't know if you've seen this, Mark, but you might have a comment.
Yeah, I mean, I do think that this could offer significant benefit here.
Yeah. And there's no reason that you would throw away single energy angles if they were useful, maybe for LET purposes, but you certainly want to include angles where you sweep through all the required energies from that angle that the optimizer prescribes.
So in looking at how the DirectARC and the hybrid DirectARC would fit into this optimization, we just added two columns to this graph, where the optimization time, because you have a direct optimization of energy for each arc angle, is actually much faster. You don't have that complexity of algorithm where you have to select a single energy. Delivery time, as we demonstrated, the DirectARC is very fast because of the very fast layer switching. Also the simplicity of the delivery. The plan quality through these optimizations of energies for each arc angle is actually superior. Dosimetric uncertainty, can be managed both from the DirectARC and the hybrid, but it is something that has to be optimized, as Dr. Newpower showed. And from a Mevion standpoint, there's no need for the DirectARC. There's no need of hardware upgrade. It is actually supported directly, as Mark was mentioning, by the technology. Skip, anything you want to add here?
Just on the black part, it really shows the progress. IMPT is everywhere. Everyone can do it. Converted static arcs have been done for a number of years now. There's a computational overhead, but they can now be delivered as a single field. And the static arc or the direct arc is the next generation of things that are supported in RayStation, and in a few centers like OU and others, they're actually beginning to use that. So it really walks us through the timeline as well.
So with that, this concludes our presentation. We'd like to thank you for spending time with us, spending this time with us. We'd like also to thank the NAPT, which has been a fantastic partner to the whole proton therapy community. Thank your partner, research, as well as Leo Cancer Care. And we would like to invite you to two exciting upcoming events. The first one is the ASTRO 2025, the Stanford Proton Symposium, which will take place on Saturday from 11 to 6 at Stanford, where the first feed system is actually being installed. And the second, it's Leo Cancer Care and RayStation or research symposium or research discussion related to the use advantage of arc therapy for upright treatment. We've received some questions here, which we will be following up on. Again, I'd like to thank the NAPT for the opportunity to present, and thanks to everybody for joining us today.
Thank you to your team, and thank you for the presenters for taking the time, and we'll get that recording out and answer these questions soon. So have a great day.